very important topic is acute pancreatitis. Now, what happens in acute pancreatitis, that due to acute pancreatitis can occur due to various causes. Okay, so if in case there is damage to the pancreas due to any reason, then there will be release of enzymes due to damage to the duct or acini of the pancreas. And then this enzymatic release, these are actually the digestive enzymes which damage the peripancreatic tissue and the other organs or the adjacent organ structures also. Okay, the pancreas is in close relation to the stomach, and there is a potential space, that is the lesser sac, which is adjacent to the pancreas. So majority of the collections or majority of the inflammation is seen in the peripancreatic tissue, that is tissue around the pancreas, and in the lesser sac. Okay, otherwise there is a very significant inflammatory response all over the body, which can lead to various organ failures and other potential problems also. Okay, now this is basically initially a patient is coming to us with complaints of upper abdominal pain which is radiating to the back. The pain is very severe and there is complaints of nausea, vomiting. And what we have to do is initially we'll clinically examine the patient, check the vitals, and then at the same time we'll have to analyze whether clinically whether the patient is having serious or the severe acute pancreatitis clinically or a mild moderate pancreatitis. Okay, and after that we'll have to get the blood test done, that is the serum amylase lipase. Serum amylase lipase will be raised. Generally in the initial time period amylase will be raised, and after 3 days generally the lipase will also be raised. And if the amylase and lipase are raised, then the clinic, along with the clinical findings, the diagnosis of acute pancreatitis is made. We'll have to manage the patient with opioids or analgesics, IV fluids, and we'll have to get other blood tests in other investigations done, and based on that we'll decide the treatment plan for the patient. Okay, now this is mainly a non-surgical disease and is managed medically. Okay, so you will be reading this acute pancreatitis in medicine also. From surgical point of view also, this is very important, and especially the severity scoring is very important, because we have to clinically and with other investigations we'll have to stage whether this patient belongs to a severe acute pancreatitis or not, because severe acute pancreatitis should be managed in ICU setting, intensive setting, to reduce the mortality. Okay, severe acute pancreatitis is having mortality of 10 to 15% or maybe even more if not managed properly. Okay, so initially if there is acute pancreatitis, we'll have to first evaluate and assess whether the patient is having severe acute pancreatitis, and then we'll have to treat the patient accordingly. Okay, now initially we'll see what all are the etiologies of acute pancreatitis. Okay, so here I've written the most common cause is gallstones. Second most common cause is alcohol. Okay, and overall if you'll see, the most common cause is gallstones. After that, alcohol. So you will get initially that there is a patient who is there is a question. For example, there is a patient who is having pain in right upper abdomen for last 3 months. Now the patient developed sudden severe epigastric pain which is radiating to back. Now what investigation you will get done to confirm your diagnosis, or to identify the diagnosis? We'll get serum amylase lipase done along with the LFT and other investigations. We'll see amylase lipase will be raised. It will be a gallstone induced pancreatitis. Okay, and alcohol intake also leads to acute pancreatitis. Then there may be pancreatic trauma. ERCP can also lead to acute pancreatitis. In fact, the most common complication of ERCP is pancreatitis. Okay, other causes can be hyperparathyroidism, hypercalcemia, hypertriglyceridemia, or cystic fibrosis, CA pancreas, or IPMN. Okay, this IPMN stands for intraductal papillary mucinous neoplasm, and it is one of the types of cystic neoplasms of pancreas, and it can involve the main pancreatic duct and can lead to acute pancreatitis. Okay. Now there are various viral infections which can lead to acute pancreatitis. The mnemonic is CME. Okay. The viruses can be CMV, Coxsackie virus, mumps, and ecovirus. Okay. Now there are various drugs also which can lead to acute pancreatitis. Earlier we used to get a lot of questions on that. So the drugs are 6-mercaptopurine, azathioprine, then deoxyinosine, cytarabine. We have tetracycline, pentamidine, valproate, thiazides, furosemide, and metronidazole. Okay, so you'll have to remember a few names because previously we have got a lot of questions from the drugs causing acute pancreatitis. Okay, now this is the etiology of acute pancreatitis. Now, what is the most common cause of death in acute pancreatitis? The cause of death depends on the like whether the patient is dying within 2 weeks or after 2 weeks. Okay, within 2 weeks, the death is most common cause is MODS or MODS. This is multiple organ dysfunction syndrome. Okay, and generally the patient develops multiple organ dysfunctions. Most commonly the patient will develop ARDS. Okay, and that is because of severe inflammatory response. And after 2 weeks, generally there will be infection, and the most common cause will be, or the most common cause of death will be sepsis. Okay, so within 2 weeks, death is because of MODS, and after 2 weeks, death is because of sepsis. Okay. Now, how the patient is going to present, what all will be the clinical features? The clinical feature will be epigastric pain, which is radiating to the back, and along with that, there will be nausea, vomiting, and the pain will increase on lying down, and the pain will decrease on bending the back and with the knee and taking their knees and elbows together. This will reduce the pain. Okay, so there will be abdominal pain or epigastric pain radiating to back. Patient will not lie down, and pain decrease by sitting and leaning forward. Okay, and pain increase by leaning backward and by lying down. Okay, another other problems will be nausea, vomiting, and abdominal distension. Why there is nausea, vomiting, abdominal distension? Because there is inflammation in the pancreas, so there will be a paralytic ileus. Okay, so there will be a paralytic ileus. Okay, on X-ray, what all findings we are going to see? X-ray findings, generally there is a gasless abdomen. Okay, sometimes there is dilated colon. Okay, so transverse colon is in close relation to the pancreas, so there will be isolated dilatation of the transverse colon. Okay, which will be like finding like this. There will be a dilated transverse colon, there will be a sudden sharp cutoff. Okay, so this will be known as a colon cutoff sign. I'll show you the diagram after some time. And this is a colon cutoff sign. Sometimes there will be isolated jejunal loop dilatation. Okay, because jejunum also is in close relation to pancreas, so that will be a sentinel loop sign. Sentinel loop sign will be isolated jejunal dilatation. Some patients, they have pleural effusion on X-ray. Okay, this pleural effusion will be more towards the left side. Okay, pancreas is more towards the left side in close relation to the tip of spleen, and the pleural effusion is also mainly seen on the left side. Okay, so the pleural effusion mainly left sided or bilateral it can be, but when we see whether it is more on the left side or on the right side, then left is more than right. Okay, now there is the terminology hemorrhagic pancreatitis. Now, in hemorrhagic pancreatitis, there is due to this severe damage, there is bleeding. Okay, so there can be bleeding around the umbilicus, or there can be bleeding around the thigh, there can be bleeding around the inguinal ligament, and there is some names given to these signs. These signs are Gray Turner sign, Cullen's sign, and Fox sign. Okay, now these are important from MCQ point of view. The mnemonic is girlfriend. Okay, so this is a Gray Turner sign is seen at the level of flanks. Okay, so there will be hemorrhage seen at the level of hemorrhage seen. Hemorrhage can be seen as ecchymosis. Okay, hemorrhage seen at flank region. So this is Gray Turner sign. Now in Cullen's sign, that is U for U, it is seen around umbilicus. And in Fox sign, it is seen around inguinal ligament or inguinal region, you can say. It is seen around inguinal region. Okay, so this is regarding the hemorrhagic pancreatitis. Now, to diagnose, what we are going to do and what is the investigation of choice for acute pancreatitis. Okay, so the investigation of choice for acute pancreatitis is CT scan. You can say CECT abdomen is the investigation of choice. Okay, and why it is the investigation of choice? Because it helps us in assessing the severity of the disease, and we will be able to identify the other associated complications or the peripancreatic complication or the peripancreatic inflammation with the CT scan. Okay, what is the best time to go for a CT scan? Best time for CT scan is after 72 hours, because the inflammation will take time to either whether the inflammation is increasing or decreasing. For a particular type of inflammation to set up, it takes generally 72 hours. So if we'll do the CT within 24 hours, we might miss the pancreatitis or the inflammation which will be developing in the 72 hours. So after after treating the acute pancreatitis patient for so long, now it has been decided that we should get a CT done after 72 hours, that is after 3 days, and then that is the best time to pick the extra pancreatic complications also, or the necrosis also, and the peripancreatic inflammation also. Okay, now what is the purpose of the CT scan? Purpose to grade the pancreatitis and to identify the complications. And what is the, you can say, what is the criteria for based on the CT scan? That is a Balthazar criteria. And nowadays we are using modified CT severity index. This is basically modified Ctsi score. Okay. So generally, whenever I am admitting a pancreatitis patient under my care, after 3 days I'll ask for a CT scan, and I'll first of all I'll see what is the modified Ctsi score. If the score is more than 8 or in between 8 to 10, then this indicates a severe pancreatitis. Okay, so we'll have to manage the patient in intensive care. Okay, and how we are diagnosing. Suppose the patient is coming to us with complaints of abdominal pain, we cannot wait for 72 hours to make a diagnosis clinically and to start the treatment. So for that, the diagnosis is made based on clinical findings plus lab investigations. Okay, and what all lab investigations we are getting done? The lab investigations are serum, amylase, and lipase. So lipase is more specific, but amylase generally, the rising trend of amylase starts early. So if the patient is coming early coming to us early, then we should get serum amylase also. Serum amylase is non-specific and it can increase in other causes of abdominal pain also. So we should get both amylase and lipase. And there is another important point. The level of serum amylase rise does not correlate with the severity of pancreatitis. This is very important. Okay, so there are multiple questions which are asked, like what indicates severe acute pancreatitis, like Ransom score more than 3, Glasgow score more than 3, amylase more than 1000. Then amylase does not rising amylase does not indicate more severe pancreatitis. Okay, so there is no correlation between level of amylase and severity of acute pancreatitis. This is very important to understand. Even if the amylase is decreasing, this does not mean that the pancreatitis is improving. Okay, so repeated amylase is not indicated. Now, how we are going to manage? So we are going to manage the patient on certain lines. Okay, we'll first give the IV fluids. Along with that, we'll start oxygen and we'll start oxygenating the patient. We'll give painkillers or analgesics because the patient is in severe pain. Then we'll have to establish the nutrition. In nutrition, we'll see enteral nutrition, that is taking normally or via rice tube feeding is more important or is better as compared to giving TPN. And antibiotics is generally not given. Prophylactic antibodies is not indicated. We will give antibiotics only in case if there is any complication or infection. Otherwise, prophylactically in cases of pancreatitis, we will not start the antibiotic. Okay. Now, regarding the fluids, what is the fluid of choice? It is Ringer lactate, very important. And oxygenation we'll give initially in all patients, then we'll get the ABG done. In case if there is low PO2, we'll start oxygenation. We'll continue giving oxygen. And analgesics, what is the analgesic of choice? Analgesic of choice. NSAIDs, in NSAIDs and in opiates. In NSAIDs, it is metamizole, and in opiates, it is buprenorphine. Okay, in NSAIDs, it is metamizole, and in opiates, it is buprenorphine. Now, next thing is regarding nutrition. Enteral nutrition is preferred. But the problem with enteral nutrition is that there is paralytic ileus and patient is not able to take orally properly. There is nausea, vomiting. So it will take initial 2-3 days for the patient to improve and to resume the oral intake. But anyways, we'll try to start enteral nutrition as early as possible. This will decrease the bacterial translocation to the gut and will decrease the sepsis. Okay, so enteral nutrition is preferred. And when we are going to start TPN, TPN is given in patients with shock and severe acute pancreatitis. Okay, so if the patient is having shock or severe acute pancreatitis, patient is on ventilatory support and is not able to take orally, then in those patients we'll have to start TPN. Okay, otherwise enteral is preferred. Now, regarding antibiotics, prophylactic antibiotic is not indicated and should not be given. Okay, so this is regarding the management of the pancreatitis, acute pancreatitis. Now, this X-ray is showing a dilated colon. Okay, this is basically a colon cut off sign. And if there is only isolated jejunal loop, you can see here there is a classical cutoff here. Okay, there is a cutoff here also. Okay, there is a colon cutoff sign, and this you can see here there is a small bowel loop which is dilated. Okay, is it visible? There is a small bowel loop, which is small bowel or the jejunal isolated loop dilated, which is a sentinel loop sign. Isolated dilatation of the jejunal loop. Okay, and this is the X-ray findings. Okay, this is the sentinel loop sign. Okay, now what is which sign is this? A. You can see here there is ecchymosis at the level of umbilicus. Then this is Cullen's sign. And here this is the flank region and there is ecchymosis at the level of flank. This is Gray-Turner sign. So they might give you this image only and they'll ask the possible diagnosis of the patient is, they will give you some vitals and then they'll give you the image and the possible diagnosis of the patient should be evaluated for pancreatitis. Okay, this is a Gray-Turner sign. Fox sign is at the level of inguinal region. Okay, now this is the CT. Investigation choice is CT, I have already told you. Now you can see this is normal pancreas. This is normal pancreas. Normal. Okay. This is normal pancreas. You can see here there is normal body, tail, there is no inflammation. You can mark the boundaries also very easily. Okay, I'll erase it for you. So this is normal pancreas. Now just see in this picture, this is picture of acute pancreatitis. You can see that here whole of the head and body is enhancing. Here this where it is written PN, this is pancreatic necrosis. So there is non-enhancing here, everywhere there is no enhancement on the contrast face also. Okay, there is some enhancement at the region of distal body and tail region, and there is some collection around the spleen here, and there is some collection here in the peripancreatic region, and along with that there is a lot of necrosis in the peripancreatic fat also. And here you can see that the boundary of the pancreas is very easily demarcated, but on the other hand in this CT the boundary cannot be very well demarcated. So this is the CT showing acute pancreatitis. Okay, now in this CT we'll have to look for the vessel. Suppose in case if you want to see, this is, we are not having whole of the picture, otherwise we'll be able to see the vessels also and some other complications, whether they are some other complications are present or not, we'll be able to see. Okay, now this Balthazar scoring and modified CTSI scoring is on the basis of CT scan. Regarding the CTSI scoring, which is most commonly used nowadays, maximum up to 10 is given, maximum points are up to 10, or you can say 0 to 10, okay, range. And in case if there is 8 to 10, in between 8 to 10 it is severe disease, okay, or severe acute pancreatitis. 0 to 2 is mild, 4 to 6 is moderate, and 8 to 10 is severe disease. Now, what all are the components of this modified CTSI score? They might give you a CT image and they might ask you what is the modified CTSI score of this particular patient based on the CT report. Okay, so there are three parameters which are included in this modified CTSI score. One is pancreatic inflammation, inflammation of the pancreas. Second is pancreatic necrosis, how much area is necrosed. And third is extra pancreatic complication, which is the main reason why we are getting the CT done. Okay, because extra pancreatic complications can be picked up by CT. Okay, now in pancreatic inflammation there are 3 points, necrosis there are 3 points, and this extra pancreatic complication, in case if it is present, then 2 points are given. So this is 0 to 4. If the pancreas is normal, then 0 point. If there is intrinsic inflammation in the pancreas only, then it is 2. And in case if there is pancreatic inflammation or peripancreatic inflammation, fluid collection, or peripancreatic fat necrosis, okay, if there is a peripancreatic fat necrosis. This is important to understand. In pancreatic necrosis, we are seeing only the pancreas, how much there is necrosis. But in case if there is peripancreatic necrosis, it will go 4 based on this criteria. Okay, 4 points. Now this pancreatic necrosis, if there is no necrosis, then it is 0. If there is less than 30% or less than equal to 30%, it is 2. More than 30%, it is 4. And in case if there is any extra pancreatic complication like pleural effusion, ascites, any vascular complications, or some parenchymal, other parenchymal complications or gastrointestinal involvement, it will be extra pancreatic complication and 2 points will be given. Here, we cannot comment on extra pancreatic complication because we are having only a single picture. We don't know whether there is any pleural effusion or ascites or vascular complication. But how much we are sure is that more than 30% of the pancreas is necrosed based on this area. Okay, this whole area here is necrosed. Okay, so more than 30% of the pancreas is necrosed, and there is some necrosis here also in the peripancreatic region. So the peripancreatic fat necrosis is there, and so there is a peripancreatic fat necrosis and more than 30% of the pancreas is necrosed. So at least this is 8. This can go up to 10 also if there is some extra pancreatic complication. So this is a picture of severe pancreatitis or severe acute pancreatitis. Okay. They'll give you that patient is having pleural effusion also and what is the Ctsi score. So this way you can calculate easily. Now there are various other scoring systems which are very important. We will discuss one by one regarding all the scoring system. First, and which is very frequently asked, is Ransom's criteria. Ransom's criteria is very important from MCQ's point of view. Majority of the MCQs are asked from the non-gallstones criteria. There are 2 criteria. There are separate criteria for non-gallstone induced, which include all the other causes, and there is separate criteria for acute gallstone pancreatitis. So we are going to study non-gallstone induced, and it is generally questions are being asked from non-gallstone induced pancreatitis only. So the way I used to remember for at admission criteria, it was WAGAL. If the WBC count is more than 16,000, if the age is more than 55, if the glucose level or the blood glucose level is more than 200, if the AST is more than 250, and if the LDH is more than 350. Okay, you will be able to understand how. Here you can write 200, here 250, and in this L there is 350. Okay, so it is gradually rising. Okay, so if the WBC is more than 16,000, age more than 55, glucose level more than 200, AST more than 250, and LDH is more than 350. That is the criteria at admission. Now, generally they are asking the questions regarding during the initial 48 hours. The problem with Ransom criteria is that it takes at least 48 hours for us to classify the patient as mild, moderate, or severe acute pancreatitis, because there is a separate criteria also here which is done during the initial 48 hours. Okay, then we'll be able to calculate the final Ransom's only after 48 hours. Okay, so what is the criteria here? If the hematocrit is falling more than 10 points, if there is blood urea nitrogen elevation more than 5, serum calcium is decreasing less than 8, PaO2 less than 60, base deficit more than 4 milliequivalent per liter, and estimated fluid sequestration more than 6 liter. Okay, so generally what they'll do is, suppose they'll give estimated fluid secretion less than 6 liter in the MCQ, you will have to mark that option. So for that you will have to understand, rather than cramming, it is better to understand. What we are trying to do in Ransom's criteria is, suppose if there is a patient who is very much dehydrated. Okay, if patient is very much dehydrated, breathless, so that is a very sick patient and a severe patient. Okay, so the estimated fluid sequestration or the third space loss in that patient will be higher, more than 6 liters. The hematocrit will be very high initially. Whenever we will be giving fluids to that patient, the hematocrit will fall. Okay, because that patient is so dehydrated, the blood urea nitrogen is high. Okay, and because the patient is breathless due to the inflammation, the PaO2 is low. Okay, and there is acidosis also, and the base deficit is high. Okay, and that's it. And in case if the calcium is low, then this means that there is severe pancreatitis. Okay, so this way you will be able to understand whether this should be more than 10 points or less than 10 points. Okay, suppose the patient is having very high hematocrit and is very dehydrated. On giving fluids within 48 hours, if the hematocrit fall is more than 10 points, this means patient was very much dehydrated. So patient had a very or is having a very severe pancreatitis. Okay, so this way you can understand. Suppose if the hematocrit is falling more than 10 points, if there is blood urea nitrogen elevation more than 5 milligram per deciliter, so patient is very dehydrated. Okay, urea is increasing or urea nitrogen is increasing. Okay, serum calcium less than 8, oxygenation is very low, PO2, arterial PO2 less than 60, base deficit is very high, there is acidosis, and estimated fluid sequestration is more than 6 liters. Okay, so this is easy to understand. Generally they'll give the same, that estimated fluid sequestration 6 liter. They'll make a mark like this, that this is more than 6 liter or less than 6 liter. Okay, so this way it is hematocrit is more than 10 points, blood urea nitrogen more than 5 points, base deficit more than 4 milliequivalent, estimated fluid sequestration more than 6 liters. Okay, only the calcium is decreasing and PO2 is decreasing. Okay, this way you will be able to identify the correct option. Okay, now there is another criteria. Okay, in Ransom's criteria, the problem is it takes 48 hours. Okay, to reach out to a final Ransom's criteria. And if there is more than equal to 3 Ransom criteria, this indicates severe acute pancreatitis. Okay. Now, there is another important score, Bicep Score. The Bicep Score stands for bedside index for severity of acute pancreatitis. Okay, and this is bedside index for severity of acute pancreatitis, Bicep. The good point is that it is bedside and we can do it straight away. Okay, there is no need to wait for 48 hours. So what is the criteria? The criteria is also can be remembered with the mnemonic Bicep only. That is blood urea nitrogen, impaired mental status, SIRS, age, and pleural effusion. Okay, and the thing is, if the blood urea nitrogen is more than 25, if there is abnormal mental status with a GCS of less than 15, okay, and if there is SIRS, that is systemic inflammatory response syndrome, age is more than 60 years, or if there is pleural effusion, okay, then each point is given 1 point. Okay, if there is blood urea nitrogen more than 25, if there is impaired mental status or a GCS of less than 15, if there is SIRS based on the criteria of SIRS, if that is systemic inflammatory response syndrome, if there is age which is more than 60 years, and if there is pleural effusion. Okay, now if the Bicep score is more than equal to 3, this indicates severe acute pancreatitis. Okay, so with a higher mortality of 15, more than 15%. Okay, now how we can identify whether the patient is having SIRS or not? So to identify SIRS, there is a criteria. The criteria is this: if there is, the points included are temperature, heart rate, respiratory rate, and WBC count. Okay, temperature, heart rate, respiratory rate, and WBC count. If two or more of the following are fitting into the criteria, then the patient is having SIRS. Okay. Why we are not taking BP here? Because if the BP is low, patient will be in shock and the criteria will shift from SIRS to sepsis and sepsis to septic shock. That is why BP is not included in SIRS. This is you have to remember. And it is temperature, heart rate, respiratory rate, and the WBCs. Now, if the temperature is more than 38 degrees or less than 36 degrees, okay, fever or hypothermia, if the heart rate is increasing more than 90 beats per minute, if the respiratory rate is increasing more than 20 breaths per minute, and if the WBC is decreasing less than 4,000 or increasing more than 12,000, or if there is more than 10% band or immature forms, okay, less than 4,000, more than 12,000, or more than 10% immature band forms. If any two of the following is there, suppose if the patient is having 13 or 15,000 WBC count and pulse is 100, then there is SIRS definitely. Okay. If the BP is very low, then the patient might have sepsis or septic shock. Okay. So this way we can calculate whether the patient is having SIRS or not, and we can calculate Bicep score. Now there is another criteria, that is a Q-SOFA criteria. Q-SOFA criteria stands for quick. Q stands for quick. Sequential organ failure assessment. Sequential organ failure assessment. Okay. Now there should be at least two or more of the following. At least two or more of the following to label the patient as having some organ failures. If the respiratory rate is more than 22, altered mental status, or systolic BP less than 100. Okay. So if the patient is having a respiratory rate of more than 22 breaths per minute, if there is altered mental status, or if there is a systolic BP of less than 100 millimeter of mercury, any two of the following is present, then there is a mortality. If suppose if there is more than equal to 2, then the mortality is more than equal to 10%. Okay. If the score is 2 or more, then at least 10% mortality is there. If the score is 1, then the mortality is 2 to 3%, and if the score is 0, then there is 0 mortality. So this way we can assess whether the patient is having serious illness or not, and what is the estimated mortality. So on the basis of that, we will be able to prognosticate. Q-SOFA criteria. SOFA stands for sequential organ failure assessment, and the criteria includes respiratory rate more than 22, systolic BP less than 100, and altered mental status. Okay. Now there is another very important criteria, that is Apache criteria. Apache stands for acute physiology and chronic health evaluation. Apache stands for acute physiology and chronic health evaluation. We are nowadays using Apache 2 score. Okay. And Apache 2 is if more than equal to 8. This indicates severe acute pancreatitis. This has been asked many times. And what all are the criteria? There are some physiological points or laboratory investigations. Then there are age points and chronic health points. Okay. So you can see here acute physiology, there are physiological points, then there are some age points, and then there are chronic health points, or the chronic long-term health points, and based on which we will calculate Apache 2 score. Generally, we are asking questions on the physiologic points. Okay, so this physiologic points is very easy to understand. This way remembering is very difficult. I made an easy way. Whenever a patient is coming, we are for acute, if we are suspecting some acute pancreatitis, we'll evaluate the patient, we'll get the blood investigation, and we'll also get the ABG done. This is easy. Now, in evaluation, we'll assess GCS of the patient. What is the GCS? What is the BP? What is the heart rate? What is the respiratory rate? And what is the temperature? Okay, this is basic evaluation. Then we'll get the blood investigation done. In the blood investigation, we'll see what is the hematocrit, what is the creatinine levels, what is the WBC levels, and what is the sodium potassium level, that is CBC KFT, or with serum electrolytes we are getting, we are seeing hematocrit, creatinine, WBCs, sodium potassium. Okay, then we are getting ABG done. In ABG we are seeing pH and PaO2. So this is basically clinical evaluation plus CBC KFT. KFT also includes serum electrolytes. Then ABG. Okay, that's it. In ABG we are seeing pH, PaO2. In blood investigation we are seeing hematocrit, WBC, creatinine level, sodium, potassium. And in clinical evaluation we are checking the GCS of the patient, BP, heart rate, respiratory rate, and temperature. Okay, on the basis of all of these we will calculate a score, and if the score is more than 8, then this indicates severe pancreatitis. Okay, now this Atlanta classification was used previously to assess the severity of acute pancreatitis. So from MCQ point of view, Atlanta criteria is to assess severity of acute pancreatitis. Okay, second point, based on Atlanta criteria, if there is organ failure, I'm repeating, if there is organ failure or local complication, then this indicates severe acute pancreatitis. Okay, if there is organ failure or local complication, this indicates severe acute pancreatitis based on Atlanta criteria. Now, what is the criteria for organ failure and for local complications based on this Atlanta criteria is, suppose organ failure with one or more, like shock is there, or some respiratory insufficiency, kidney problem, or GI bleeding. Okay, any other organ system is involved. Okay, if there is shock is when BP is less than 90, and if there is pulmonary insufficiency, PO2 less than 60, then this indicates severe acute pancreatitis. Or if there is renal failure, serum creatinine is more than 2 even after rehydration. Okay, then this means kidney problems or renal failure. And in case if there is GI bleeding with more than 500 ml in 24 hours blood loss, so this indicates organ failure. Okay, based on Atlanta criteria. Now there is local complications. Pancreatic necrosis, if it is more than 30% of pancreama or more than 3 centimeter. Development of pseudocyst or abscess, that is pus collection, which is organized pus collection, pancreatic abscess or pancreatic pseudocyst. Ransom criteria, if more than equal to 3, Apache 2 more than equal to 8. Okay, more than equal to 3 or more than equal to 8 is severe acute pancreatitis. Now, what all are the points which are for the severe acute pancreatitis? If the Ransom score is more than equal to 3, it is severe acute pancreatitis. How we are calculating Ransom score? For non-gallstones, at admission at 48 hours, 5 criteria for at admission, 6 criteria for at 48 hours or during 48 hours. After 48 hours, we will be able to calculate Ransom score. Modified Glasgow, if it is more than equal to 3. Bicep score, that is bedside index for severity of acute pancreatitis, if it is more than equal to 3. Apache 2 score, acute physiology and chronic health evaluation, if it is more than equal to 8, this is severe pancreatitis. QSOFA, sequential organ failure assessment, quick sequential organ failure assessment, more than equal to 2. Modified CT severity index, also known as modified CTSI, if it is more than equal to 8. This includes pancreatic or peripancreatic problems, necrosis of the pancreas, and extrapancreatic complications. And if the CRP level is more than 130 milligram per milliliter, then this indicates severe acute pancreatitis.